Tonight, the webinar is on challenging cases, the irregular cornea, and we have Professor John Mehta speaking first, and then Dr. Greg Moloney. Now, a lot of you probably are already familiar with Jod. He's a distinguished professor at Duke NSU, based at the Singapore National Eye Centre, and there he's head of the corneal surface, head of the Tissue Engineering and Cell Therapy Group at the Singapore Eye Research Institute, and named Professor of Clinical Innovation, again at the National Eye Centre. He's well published, has over 9,000 citations and given over 250 invited plenaries. So we're glad that he'll be able to add this one on to his list of plenaries tonight. And he's both a clinician and a researcher. Thank you, Jod, for your time.
So thanks for the invitation to talk about, so we're doing lens-based management of irregular corneas. Let's go for this one here. Okay, so these are my disclosures. They don't really pertain to what I'll be really talking about today. So first, we're going to start with some definitions. So the first thing to define is what exactly is an irregular cornea. And Duke Elder basically defined this as a cornea in which the refractive meridians do not conform to any geometrical pattern or known geometrical pattern itself, and the refracted rays have no planes of symmetry. And this was basically true until we had computerized video topography, and then we could get a much more detailed analysis of the cornea. And what it basically showed us is that there are lots of different patterns of irregular astigmatism, and we can define this into two main types: one which we call regular irregular, and one which we call irregular irregular. And the difference is that it's got to do with the different hemimeridians. So when you're looking at irregular astigmatism, it's really important to analyze the hemimeridians with respect to their symmetry or their asymmetry as well, and to see whether they have any sort of form of recognized pattern within the hemimeridians themselves. And all the topographers or tomographers that most of us use these days for refractive surgery will allow you to basically do this analysis. If you look at the causes, you can divide them into two parts, so primary and basically secondary. I think most causes of irregular astigmatism are actually probably secondary. So and you can see the major disease foci are related to either ectasia, so either keratoconus, PMD, or keratoconus globus, corneal incisions, so post-infective scarring, post-keratoplasty, or after refractive surgery. And this is either PRK, LASIK, RK, or basically AK. So as a corneal refractive surgeon, you're almost certainly going to come across patients who are going to basically have irregular astigmatism that you're going to have to basically deal with. When we look at the incidence, I basically think it's very similar to the US treatment of basically, or Trump's treatment of COVID-19. If you don't look for it, you don't basically have it. And I seem to find it a lot because I look for it in a lot of detail. But of course, if you don't look, you're not going to see it, and people are going to basically not make the diagnosis. So I think that with the modern day available topographers that we have from refractive, once you start using this much more in your corneal clinics, you're going to see a lot of cases that you're going to basically have to manage. And I think a lot of unhidden irregular astigmatism is why people are unhappy when they go for trifocal or basically some of these non-standard IOLs following the outcome, following their surgery, because it's basically been missed preoperatively because they haven't been assessed in detail. The treatment for a lot of irregular astigmatism, of course, is based on three things. One is basically rigid gas permeable contact lenses, which will neutralize the effect of the irregularity on the surface. It can be excimer-based treatment, which is normally topography guided to smoothen out the surface. A lot of times you can't get complete smoothing of the surface, but you're trying to get it a little bit more even. Or it can be basically lens-based surgery, and this may be performed with one of the other two things as well. Often I will always put the patients into RGPs, especially after grafts, just so they have an idea of the feel of what it's like. And if they're intolerant, at least they know they basically tried it before, or you can use it as a diagnostic lens. Sometimes I'll combine some of these treatments with excimer-based treatment before you'll do the lens-based surgery. And the idea is try to get the surface a little bit more regular before you'll basically do the surface surgery. And I'm going to show examples really of trying to deal with these situations in these irregularities. So most of them were graft related or refractive surgery related or in primary ectasia. So we'll see how you'll basically handle a lens-based surgery in keratoconics, lens-based surgery in graft surgery, and a lens-based surgery in somebody who's had previous graft surgery but who's in a slightly older age group as well. The key thing to really take point or to remember is that the correction will, the lens itself is going to give you the same power correction in both the hemimeridian. So hence, there will be some residual undercorrection, especially if they truly have a lot of irregular astigmatism. So you're only going to try to correct the regular amount of the irregularity, there will be some irregular astigmatism left over itself. And a good idea is to basically look at what their glasses visual acuity is itself. Somebody who loves wearing their contact lenses for a long time, do not even try to offer them that they're going to get anything like the quality of vision they would get with an RGP contact lens, because it's not going to basically happen when you basically use a lens-based treatment. So the first thing is how you assess the patient. So here's the patient over here. You can see on the orb scan, there's 8.3 diopters of astigmatism on the surface over here. And initially, when you see this, you think, okay, what's the issue with basically the surface profile? Now, if I show you this on this side, of course, it looks completely different. And now if I tell you that this is exactly basically the same patient, you'll understand that basically what you're seeing is that the difference in the scans is because of the steps are actually different between the two scans. On the left-hand side, you're looking at 0.5 diopter steps, which is typically what we use for refractive surgery. And on the right-hand side, you're looking at 1 diopter steps. The reason why you can't see anything is the astigmatism is so high that basically everything basically looks massively elevated because you're looking at 0.5 diopter steps. So it's important that you get the right scan and you look at basically the step coloration. And normally I'll use 1 diopter scans when you're looking at your refractive patients if they're post-graft or in this situation. Now, interestingly, when you look at this scan, it was documented in the notes when this patient was sent to see me that they had regular symmetric oblique astigmatism, because it looks as if it's symmetrical on at least on one axis, but this axis over here doesn't look quite like, if you look at the basically coloring on the picture, it looks like it's slightly higher on this side and lower on this side over here. So possibly 45 on this side and possibly 50 or 59 on the opposite side in that meridian. If you look at the pentacam, it allows you to do a little bit more quantification. And in fact, when you look at the pentacam in a bit more detail, what you can see is there's almost 5.5 diopter difference in the treatment across the hemimeridian, across this side, and across the total side over here, there's almost 8 to 9 diopters difference in treatment as well. So now you can elucidate a little bit more clearly, this is in fact, it is irregular astigmatism, and your management is going to be very different than if you thought it was basically symmetrical oblique astigmatism, where you may even think about putting a toric lens in straight away in this individual, while here I would think about doing some graft refractive surgery in the forms of an arcuate keratotomy, asymmetrical arcuate keratotomy, related to the fact that there's a difference in the amount of astigmatism before I'd even think about putting in a toric lens. And going along with this, you can see a high amount of spherical aberration in this example as well. So here we go. So this is the first guy I'm going to show you. He's a 26-year-old gentleman, basically with keratoconus. He came for a LASIK assessment, so high myopia, keratoconus worse on the right side compared to the left side. He went for contact lens fitting, was only able to wear the lens for basically 3 hours, so was contact lens intolerant. On the right-hand side, I did a basically big bubble dot for him. On the left-hand side, he had collagen cross-linking, and normally once this is basically stabilized, he didn't want to wear his glasses, he wanted to undergo some sort of refractive treatment. Now you can see over here, he's got an asymmetric bow tie on this side, basically from his orb scan. Low degrees of astigmatism, about 3.9 diopters. So this is a good candidate basically for ICL. Now he's not going to get a basically perfect result, but I'll show you one on the next couple of slides due to his coma. The sizing is best to do because these patients often have deep anterior chambers. So I'll use basically a UBM to basically do the sizing. I won't do a clear corneal incision in these patients. I prefer to do a scleral tunnel. So you wet away from touching the cornea. Generally, in these biomechanically unstable corneas, you have a higher risk of inducing a bit of biomechanically instability, even with your corneal incision. And likewise, in the future, even though he is cross-linked, he is only 28 when I did basically the surgery. If he does progress in the future, it's still possible to do a big bubble dot basically inside this eye. Generally, I'll choose ICLs that do not allow you to basically have to rotate the lens into position. So normally you only have to get one axis correct and the lens will automatically neutralize the effect of the cylinder on the correct axis. So this is what he was basically like pre-op. This is basically what he's like post-op. He's got a nice basically vaulted lens with a basically deep anterior chamber where he's sitting, and he's got a pretty reasonable refractive result. You have to bear in mind that when you look at the outcomes and you compare ICLs in keratoconic patients compared to ICLs in myopes, the keratoconic patients are gonna basically do worse. So you're not gonna expect to get the same visual acuity results. So it's important to basically counsel the patients beforehand or pick and choose the right patient before they undergo surgery. And the reason why is that, of course, they still have high amounts of high ward aberrations in the cornea because, of course, you're not basically correcting that. What you're doing is you're putting a lens in to basically neutralize lower order aberrations, and the higher order aberrations, especially the coma, is still going to be there, and that's what's basically going to lead to their visual effect on their visual quality compared to what you see in our standard toric lenses in high myopes. So the other cases that you may see are basically in your graft surgery. So typically following a dog, this is a patient with Avellino corneal dystrophy. You then get faced with a situation like this. And then 3 months post-op, he has about 8 diopters of astigmatism. So this is obviously one of Greg Moloney's grafts that came to Singapore that I ended up having to see. So when you see him basically post-op, you basically wait. And of course, before you consider doing any management with respect to their graft refractive procedure, you must basically try to remove the stitches. And everyone in the olden days, when we were doing a lot of PKs, will understand about chasing the suture astigmatism down, and you wait, you take your sutures out, and you basically wait again. And just by basically doing good selective suture management, you can reduce the astigmatism down to basically a reasonable level and leave him with basically a few of the stitches remaining, and he gets pretty good visual acuity that you can correct with glasses. So with the graft, you wait, you don't go ahead by basically doing any graft refractive management until all the basically sutures are out. So here we have another case of a patient who had a graft done back in 2004. His visual acuity was quite poor following his graft. His refractive error was about -13.5, giving him basically 615 visual acuity. So he tried an RGP contact lens. He had a basically poor fit with basically poor wear time. So his visual acuity potential was actually quite good. He was able to get refractable after he had his stitches basically removed up to 6.9 vision over in his right eye. He came to see me in 2009, but he kept on coming back to the clinic once a year, and people used to basically refract him, but they actually weren't doing anything about his visual acuity. So they weren't actually giving him any improvement in his vision. He had all his sutures taken out. His unaided visual acuity was basically 6/120. I tried him with a lens. He was intolerant. And then we decided basically to go for ICL. And you can see from his astigmatism over here on his pentagon map, it's quite regular. It's a little bit irregular in the fact that the top half is not as good as basically as the bottom half. And you can see this on his curvature map with respect to his K readings. You can see there's an asymmetry there between the superior and inferior side. So you don't expect to get a perfect result. I thought it can get him slightly better vision than he's currently getting now. Because of his age, he was better off going for a toric ICL as opposed to an intraocular lens. So again, the surgery, I try to pick an ICL that I won't have to rotate because they have a high degree of basically movement inside the eye. I try to pick a lens that you just basically put in pretty much horizontally into position. Of course, you need to check his endothelial cell count. This is an old graft. This is a 6-year-old graft, so his cell count is bound to basically be lower. So you make sure he has enough endothelial reserve before undergoing his surgery. But the rest of the surgery is pretty much routine, putting in normal ICLs as you would do in a non-grafted patient. So this is basically pre-op over here. This is post-op. So he's got a nice vault on basically on his graft, and his endothelial cell counts seem to maintain quite well. So this gives you a reasonably good idea on what to handle basically in these post-graft patients. So what about a little bit more complicated case where you have a patient that we're doing the graft first of all? So here we have a lady who has an IK scar with an atrophic macula. Her PAM gave her 621 on this side, and you can see on the ASOCT that her IK scar actually goes quite deep, okay, right onto descemet's membrane. So you know already preoperatively, if you're going to basically do a graft for her, or you're going to try to attempt to do a dog, you really need to go down to basically bare descemet's membrane. So we use a combination of techniques. I try to do an air separation over here, which can be quite difficult if you have IK scar to get a plane. And then I switch to a visco bubble technique where we will dissect away the stromal fibers using viscoelastic. Viscoelastic allows you to penetrate into different planes. The downside of using the viscoelastic is that, of course, you must make sure you bare descemet's membrane or bare at least Dewar's layer to make sure that you remove all the viscoelastic because you can't leave anything remaining behind. But once you basically got the planes do open up quite nicely, and you can get a very, very deep dissection with this technique, and then you put your graft into position on the eye. So post-op, she was about 12 months post-op. I took out some sutures as well. So she sected suture movement. She was getting about 624, so not too bad. Bit of a cataract. Eventually, after I removed all the sutures, she was getting about 4.5 diopters of SIL at 24 months post-op. This is her topography. So reasonably regular, basically on this side. Lens I prefer to use is a Zeiss lens, because Zeiss lens gives you a bit more tolerance, and I find it more stable inside the bag. And you can see the calculation done on this side over here and the position. And normally this will go obviously on the steep axis of basically of the patient as well. Okay. So again, the surgery, often if you're doing these cases in previous dogs, it's quite good to use vision blue, because sometimes when you're doing a coaxial illumination on the interface can sometimes affect your visual quality. Again, the lens position I find with the Zeiss lens gives you quite good tolerance. There's very little movement. It's normally, I find, much more stable. And it does allow you to correct slightly higher diopters of astigmatism compared to, let's say, J&J or basically the Alcon lens. And generally, I'll always suture these incisions because you have differences in your tractional forces between the edge of your graft and your corneal incision. So this is what she was like basically pre-op. This is like basically post-op. This is basically, she's got pretty reasonable vision now, 612 on the side, and still maintaining quite a reasonable cell count of about 2,000 after her dot in her eye as well. So the issues that we basically face when you're doing these calculations is basically getting accurate measurements, both of the keratometry and also of the axial length as well. And there's a lot of assumptions when we're doing the calculations, because as you can see in this diagram over here, when you look at the central axis, you can get hemimeridian with almost 15 to 16 diopters difference across basically the central area. And this is going to affect the outcome when you're basically choosing your intraocular lenses. A lot of the measurements that we measure are not basically valid in keratotomic readings. And there's certain papers showing you that almost 26% of patients who have refractive lens exchange, who have keratoconus, almost have to have a lens exchange afterwards because of the issues with the degree of accuracy with respect to their biometry errors. We also have the face that often these patients are myopes, so they often have larger axial lengths. If you look at the accuracy or the fixation accuracy in patients with normal control myopia compared to myopes with higher axial lengths, you can see their fixation is generally quite poor, and you get they can be all over the place when you're doing fixation. They have deeper anterior chambers, so their effective lens position can be affected. And you have to remember, of course, when you're thinking about putting a toric lens in, you've got to think about the posterior corneal curvature. Now, I know a lot of the new fourth generation formulas basically take this into consideration. I think it's important to consider that, especially if you're putting it into a mild to moderate, basically keratoconic. Also, we have to bear in mind that sometimes it can be difficult to obtain good K readings in patients who are long-standing contact lens wearers, because of course they may basically deal with corneal warpage. And if they're happy with their contact lenses, and you think they're happy to wearing the contact lens afterwards, don't stick a toric lens in as well, because basically stick a monofocal in, let them go back to basically wearing their contact lenses afterwards. The biometry measurements, I mean, optical biometry is obviously considered probably the gold standard. Generally, you get an underestimation of the IOL target power, which can lead to postoperative hyperopia. If you're doing keratoconic cases, you can stratify it preoptically depending on the K readings. Generally, if your K readings are higher than 55, they're going to get a pretty poor result unless they're willing to wear back their own contact lens. So then you have to think about altering the corneal topography first of all before you basically do anything with the lens, if they're not going to be happy with the visual acuity result. Mild to moderate cases, they seem to be more accurate. Likewise, the biometry iris seems to be more accurate in those cases compared to the more severe cases, which are over 55 diopters. What's the best topographer? Well, obviously the answer is there really probably isn't one best topographer. Normally I'll use 2 or 3 topographers to look at the differences in the readings. Normally we will use either a shine fluid basically based system, but I'll also basically use a Placido based system. If you have the Cirrus, this has this basically combined all in one shine fluid and Placido. But normally I'll use 2 or 3 scans from different machines to really have a look at the surface topography before we do the IOL biometry. And I think it's important to do that to see basically what you're dealing with. Formulae, most of the studies on the formulae have actually been using 2nd and 3rd generation formulas, which is not what I use. I prefer to use Barrett, as I basically show you in the last couple of slides. I think that's probably giving you the most accurate. Most of the studies have used topography guided K readings to give you your basically measurements. And for mild to moderate astigmatism, they normally use SRKT. Again, severe results, severe K readings or steep Ks above 55, you're going to get a poor result pretty much whatever topography you're basically doing. Some people actually even use just basically standard Ks, but you're going to get a poor result with that with respect to quality vision unless they can go back and wear their contact lens afterwards. You can combine the procedures. Sometimes if you have a very displaced cone, you may think about putting an ICR ring, cross-linking basically on the surface, and then basically do the cataract surgery. And of course, intraoperative biometry, say using the ORA, it can be quite useful. Again, a little bit depends on the positioning of the cone in relation to the visual axis, okay? Because obviously your central K readings, where your optical zone is going to basically be the most profound effect on your visual axis, which may not be where the steepest point of the cone is as well. So that makes it a little bit more tricky to basically do your calculations. But it's important when you're doing these keratoconic cases that they are basically stable. When you think about wound, this is a patient of mine, basically with keratoconus. You can see a little bit of asymmetry, almost a diopter across the central axis using the Callisto, basically, where we put the toric lens in. Generally, I'll use a modified scleral tunnel approach, so I won't basically touch the cornea to reduce any induced astigmatism on the surface. And most of the times, I would actually just use a monofocal lens. I won't basically use it. I'll only use a toric lens in mild to moderate cones that I know have been absolutely stable. So we have some good biometry, and to make sure that you've got good stability, it's quite useful to use the OCT to make sure you remove all the viscoelastic from behind the lens. This lens is actually quite a big lens to put inside the eye. So as I mentioned, for mild degrees of astigmatism, mild to moderate degrees, I would basically consider doing a toric lens, especially something like this, but you warn the patients there's going to be some degree of undercorrection. And likewise, as I said, if they're happy with their RGP lenses, do not put a toric lens inside the eye as well. If you look in the literature, you will see papers actually, ironically, for patients who have keratoconus or mild keratoconus who've actually had trifocals in. I find this quite difficult to believe that this is even possible. And the reason why I personally find this difficult is that even in this example over here, so this is one of my patients on his right eye, so even though the astigmatism doesn't look so bad, so I think this is probably doable with a toric lens, I would never put a toric multifocal into this patient because of his high degree of coma. So how you would actually choose a patient that you put a trifocal in where you're splitting the image up even more, I find it very difficult to believe that this is possible for a lot of our patients with basically cones. So the challenge that we're left with is really trying to get depth of focus in an irregular cornea. And I think this is the holy grail that we're basically trying to look for. And we know that this lens, basically the IC8, is a small aperture focused lens. And the idea is with the small aperture is to extend the depth of focus, which gives you the tolerance to astigmatism and the resistance to higher word aberration, which is some of the issues that basically I've been talking about that we have when we're doing these kind of cases. And I'm just going to show you the lens to insert the lens. Probably Greg will show that in a video, so I'm not going to show that, but I'll just show you some cases of patients that we've used the lens in. So this is a 66-year-old Chinese gentleman with a herpes zoster scar that's been active for years. And he has left irregular induced astigmatism. And interestingly, the scar is actually not that bad. You can see it basically over here. But if you look at his astigmatism, he's almost got 10 diopters of induced astigmatism across basically the ocular surface. And he's got associated negative induced corneal spherical aberration. And likewise, he's got a lot of vertical coma. He's right eye dominant in the side as well. So I did a IC8 for him using basically flax because I wanted to neutralize this effect of astigmatism on the surface. So 1 month post-op, he's reasonably quite good, 612. N8 for intermediate and basically 5 for near. The other eye, he's basically got a he's got a monofocal lens in that I basically did for him basically afterwards, just monofocal setting for distance. At 3 months post-op, he settles in quite well. I do find that, especially with these patients with ocular surface disease, you must basically treat this ocular surface. So he has a punctal plug inside the eye, lots of basically lubricants to help him even out the ocular surface, especially if they have induced irregularity, because it will affect the quality of the vision that he's able to read from this side. But he's got a pretty reasonable result, even though his hemimeridian is almost about 9.6 diopters across the central visual axis. So what about in refractive surgery cases? So here we have a 75-year-old Malay lady. She's an orthodontist. She had hyperopic LASIK in the past, and she has bilateral Fuchs, bilateral cataracts. She's basically right eye dominant. So this is a typical hyperopic, obviously, ablation profile. If you look at her spherical aberration is minus 166 on both eyes. So she had a lot of negative spherical aberration. And her Fuchs is quite mild. Her cell count is 1908. You see the Gutte basically over here, but she doesn't have a lot of haze or a lot of glare from basically her Gutte. So the right eye, she had a monofocal lens put in. I used an SA60, so a spherical lens, to reduce some of this high minus spherical aberration. The left eye, she had an IC8 put in, basically after we'd done the monofocal, and 3 months post-op, you can see she's got pretty reasonable visual acuity, so 6.9. Reading vision, intermediate, both N5. Binocularly, she's basically 6.6, but obviously she's got good vision basically on the other side. Using, again, lots of lubricants. You can see over here, a LASIK flap on the side over here. This is a corneal incision that we created with the femtosecond laser as well. And now she tells me she only uses, she's about 2 years post-op now, she's still maintaining very good intermediate near vision. She only uses loops basically when she's doing root canal treatment. Otherwise, she's pretty much spectacle independent. So what about myopic LASIK? So this is the opposite now. So you see very flat, basically corneas. So this 59-year-old Chinese guy had myopic LASIK done 10 years ago. He's also an NTG, POAG suspect, even though in the notes, his highest IOP recording is basically 17. His fields have been stable on ASOP. He had bilateral cataracts. He was right eye dominant. You can see a lot of positive spherical aberration over here. 566 on the right, 687 on the left-hand side. So he had a right monofocal lens, cataract surgery. So I used a Zebu on this side, which is a negative aberration. So it's a spherical aberration lens to reduce some of that positive aberration, which obviously is different to the previous patient. On the left eye, we put an IC8 in, and at 3 months post-op, he's getting pretty reasonable distance vision, very good intermediate, very good near, and binocular, he's very good. He's got good vision in his other eyes. And again, lots of topical lubricants on the surface because he's a bit younger than the previous lady. He finds he's not so sensitive to the lubrication as basically she was. But the most important thing also is that when I send him to the glaucoma team, they can easily assess his optic disc through that small aperture of 1.36, both with RNFL, visual field, and also with optic disc photography as well, so they can monitor his pressure, which, as you all know, is very difficult to do in people who've had previous LASIK done in the past. So the last case I'm going to show is another high myope case, which is basically a guy with bilateral cataracts with a disc suspect. He had a cataract surgery done in 2016. His left eye basically dominant. They put in a monofocal lens and he got a pretty good visual acuity result. And here you can see a lot of spherical aberration over here, 1.209 and minus 0.896 on the left-hand side. So he underwent right side flax, which is on this side over here. Pretty good visual acuity result at 3 months, both for distance, intermediate, and basically on near. Again, needs a lot of lubricants basically afterwards. He's a refractive surgery patient, and of course had a previous flap, so of course he needs a lot of topical lubricants. And interesting, if you do a KR1W to assess his barometry, you can actually see the effect of the IC8 lens. So if you look at the left-hand side, which has the monofocal in, and you look at his aberrations over here, so his spherical aberration over here, you can see it's all coming from the cornea, nothing basically from the internal side. And if you look on the other side over here, on the right-hand side, that has the IC8, you can see his corneal aberrations over here, and you can see this deep blue, which is the negative side, coming basically from his IC8 lens. And what's happening is his IC8 lens is neutralizing the positivity of his corneal aberrations, and that's what's giving him basically some much better visual acuity results. And you can see the effect quite nicely with the KR1W assessment of his internal and external and corneal aberrations. So in conclusion, lens-based surgery, I think, is good for mild to moderate amounts of irregular astigmatism. You won't achieve a full correction of the astigmatism, but you can probably get a reduction between 60 to 80% depending on patient selection. I think patient selection and counseling is really important before you undergo basically put the lenses in the patient's eyes. In keratoconus, you need to consider disease progression. Generally, in the younger patients, I do cross-link them all beforehand and wait until they're basically stable. If they have a graft, of course, you must basically remove the sutures before you're considering any graft refractive basically surgery, and wait for it stable for at least 3 months basically post-removal, ideally as long as possible, but at least a couple of refractive readings that have been exactly the same. If there's a difference between the pre-op visual acuity with the contact lens and the spectacle lens, you must basically tell the patients that it's unlikely they're ever going to achieve what they're going to basically see with that contact lens in situ. So it's important that they understand that beforehand, because you're never going to achieve that with a lens-based treatment as well. With respect to IOL selection, you need to choose the appropriate IOL depending on the amount of spherical aberration. Obviously, if it's a hyperopic lens, you put a spherical. If it's a hyperopic ablation, you've got a high level of negativity, you put a positive spherical aberration lens in. If it's a myopic lens, you basically go the other way around, basically reduce the amount of spherical aberration as well. Whether you can put a toric lens in, you need to basically think about looking at the anterior and also based on the posterior flow, and also to assess the patient to see if they're contact lens intolerant. The newer generation formulas, basically I use Barrett 2K for all my calculators for the refractive surgery patients. I think that basically it's much more accurate compared to the older generation formulas. Thank you for your attention.
Thank you, Jod. That was great. Now we're going to hold over questions and a bit of discussion till after the next speaker. Okay. Who I'll introduce in a tick. But while we're all here, I'd also like to thank Dr. Con Petzoglou, who did a lot of the behind the work scenes to get the webinar happening tonight. Thanks, Con. So our next speaker is Greg Moloney, and his bio is actually that he grew up in Wagga in New South Wales. Those of you not from Australia, it's a small town somewhere in the middle of somewhere. And he does his best, but honestly could pay more attention to his dress sense.
This is the bio I provided for you, Stephanie.
That's right. But seriously,
can you also add that between Jod and myself we have 9,010 citations? Can you just
9,010 citations, and Greg's adding another one to his talk list tonight. But he's one of our esteemed corneal specialists and oculoplastic specialists at the Sydney Eye Hospital. He's trained internationally in Canada. He regularly speaks around the world and runs KPO clinics and does other complex things at the Eye Hospital. Thank you, Greg.
All right, thanks, Jod. I've had to follow Jod a few times in webinars and talks and things. It's a very frustrating experience. But what I'm going to do I'm just going. What I'm going to do is just give my perspectives as a corneal surgeon who's been using the AcuFocus for around about, I think about 12 months, a bit longer, and just some practical tips on what I've noticed in the first few cases in the different clinical settings that I've tried it, and just a few little practical tips on the IC8 lens in particular as treatment for irregular astigmatism. It's been, definitely found it a useful and interesting addition to your choices of lens as a corneal surgeon. And I think I'm already glad that it's part of the lenses that we have to choose. The situations that I've tried it in my practice are post DWEC surgery, post DMEC surgery, in contact lens dependent keratoconics, who were trying to transition from contact lens to other refractive solutions. The one that David Holland would rather I do it in most often would be the routine cataract patient coming to cataract surgery looking for options for glasses independence, and we've also done it in post-radial keratotomy. So I'll just show you some of the things, some of the outcomes quickly that we've got. I'll just share a few quick pearls. And there was one morning last week as I was preparing this talk for tonight where we had two cases come across the desk, come across the clinic, very quickly that I thought I sort of had to mention. This is one of them. I got a request from another corneal surgeon saying, "Oh, what do you think about this cornea?" Which is, you can see it's a very blurry screenshot that I received in an iPhone. I'm saying, "Do you think this might be something that would be good for an IC8 lens?" The first point I'd make about the IC8 lens is I hope this doesn't become a solution to any irregularity in the cornea when in fact there's a better solution to treating irregular astigmatism in the cornea. And this was a post-pterygium patient who had developed some pre-Bowman's scarring. And my response to the request for help was, "Can you just send me an anterior segment OCT?" And you can see anterior segment OCT that there is a sort of Saltzman nodule above Bowman's membrane, which we know is an easily treatable surgical challenge. This same patient came to my clinic having had just that, and we had a pterygium patient who had 12 diopters of topographic astigmatism, and post superficial keratectomy as part of the pterygium procedure is down to 0.8, the normal looking topography there on the left with the pre-op centrally there. So the pearl number one is make sure that if we're reaching for a lens-based solution to corneal astigmatism, make sure there's not a simple a solution in the cornea. And the simplest of all, and the most dramatic that I enjoy treating is when you have a patient come across your desk with a wildly irregular topography, but all of the pathology is pre-Bowman's, which is easily addressed with a superficial keratectomy, with a peeling or a wiping technique, and then allowing the cornea to reepithelialize can be all that patient will need. There's a structure in the back of the eye called the retina, which we may not often pay that much attention to. But this patient also, this was a referral from an optometrist to see whether we thought an IC8, we'd had some recent success with the IC8 in some other patients, and I was asked, would this patient be a good candidate? And I noticed in our clinic file that my colleague was treating the retina as well. And I think there has been early feedback from our retinal colleagues about this lens, which is generally supportive that most retinal treatments can be conducted through with an IC8 in place. But I'm still hesitant in my practice to offer that when there's a possibility of particularly focal laser, which is an increasingly rare intervention, but certainly diabetic or other retinal pathology in the central paramacular region. This I found also. It was my son had his 9th birthday on the weekend, and he got this book. He got this book as from a friend of his, and it was How Things in the Body Work. And there's a page in there called How Vision Works, which I found very interesting. And even my 9-year-old son can tell you that when the pupil opens from its smallest to its fullest diameter, 20 times more light enters the eye. And that's certainly the biggest thing that I've noticed, and that I counsel anybody receiving an IC8 patient preoperatively now, is that your scotoptic vision will be noticeably different. And in the early, with some of the early visual results I was getting with the IC8, I became very impressed and was very, very excited by some of the visions we were recording. And in 1 or 2 early patients, actually with bilateral keratoconus, implanted bilateral lenses. And what I found in that one patient was it was just too much for him to tolerate the reduction in contrast sensitivity in brightness at night. And this is what happened to that lens in the second eye that got implanted. It came out again. So in my practice, it remains a unilateral option. I don't know, Jod, what your comments there might be, but that's for me one of the early lessons that I learned. Interestingly, that patient described difficulty in dusk driving. Driving at dusk in low light became very, very hard. When it got even darker and the pupil became bigger, there was perhaps a bit more light entering around the edge of the pinhole aperture, and he actually found it became easier in very dark conditions than it did in moderate low light. We have one patient who complains after receiving the IC8 that they get diplopia in low lighting conditions and some interesting dysphotopsia. We presume because he's getting a sort of a polychoric effect from the crescent of light around the edge of that implant. And now we screen all patients preoperatively for a mesopic pupil size, and we're exercising caution if it's above 5 millimeters. Certainly, in all of these patients, I've found it very useful to have some centration software as part of your surgery, because it's not always going to land directly in the right spot on the pupil. And I have had patients. I've had one patient who I've returned to theatre specifically to reposition this lens on the pupillary axis. So I use the Varion system with pre-op capture of the pupil position, and then make sure that we pay some attention to putting that pinhole in the right spot. The other point I'd make is that if you're only isolating the central at this point in time, until there are possibly other sizes available, but you're only isolating the central 1.36 millimeters of the visual axis. That's around about the central 1.6 millimeters at the corneal plane. And if that is still a rotten area of cornea, you're still going to perhaps not have a magical effect, a visual effect. And I've asked David to provide us with, so I mean, when we do a test, the testing that we do in our clinic for an AccuFocus in our keratoconics is if the spectacle, as you said, John, in your talk, if the patient can refract to a good level of vision with a pair of glasses, in other words, if a symmetrical piece of glass in front of the cornea can give you good vision, then a symmetrical piece of plastic behind the cornea, like a toric lens, might also give you good vision, but more often than not, that's not the case. And their pinhole vision or their RGP vision is better than their spectacle vision. And it's those patients that we're looking at for the IC8 lens, but the pinholes we're putting up, none of them are 1.6 millimeters in diameter. You're always going to get with your simple pinhole in clinic, a better impression of what the AccuFocus or the IC8 will do than perhaps what it actually will do. And I have had 1 or 2 cases where the AccuFocus vision did not match the pinhole vision that we achieved, that we measured with our standard pinholes pre-surgery. This is a small series we're about to publish in the Journal of Cataract and Refractive Surgery, or we're about to submit to that journal, which was the use in contact lens dependent keratoconics of a 2-step procedure. So these were 3 patients who had very high refractive error, myopia in the sort of -10 or below range, all dependent on rigid lenses for vision. And what our strategy was to use the IC8 to reduce the refractive error, and then as a second stage perform topography guided PRK and collagen cross-linking to normalise the corneal profile. And you can see in the bottom right series there, a patient's Penacam pre, post, and the difference map that the topography guided software can provide. And it's a powerful tool for, it can be a powerful tool for regularizing a corneal shape, particularly coma. It's really good at elevating Ks in one half of the cornea and flattening Ks in the other. And you can see in that difference map in the bottom right there, that's a fairly classic topography guided PRK difference map. What we found in these 3 patients was that after the IC8 went in, the spectacle corrected vision was okay. we were certainly able to reduce our refractive error significantly. But then what it really did was open up the door for a topography-guided PRK procedure, which reshaped the cornea. And because of the reduction in refractive error, we didn't have to expand or expend a lot of tissue. It reduced the amount that we needed to take. And then with that second step, really quite impressive visual results were able to be obtained. All of these patients are 6, 7.5 or 6.5 in spectacle, in glasses now, having come on that journey from rigid lens dependence. So I found it to be a very useful addition to that algorithm. This was a patient who came along, a standard cataract referral requesting glasses independence, but with a low or with a mild to moderate cone that hadn't been detected by a referrer or never understood to be there by the patient because the refractive error wasn't significant. But clearly that topography on the left there is not one that we would be offering other multifocal solutions to, certainly not in my practice either, as John suggested. So this is a patient who we said, well, look, why don't we try an IC8 for your worse eye? And the results there on the left in her were quite impressive. Unaided vision of 6.5 in both eyes, but in the eye that received the AcuFocus N5 reading, I think that was a generous N5 by my orthoptist, and I think with a plus 1.5 sphere, it was a more reasonable N5. But certainly functionals without glasses in most activities in life now. The other tips, the general tips that I sort of impart about using it are, there's no sort of specialty, quote unquote, specialty lens that I've put in that I've never ever had to take out in some percentage of patients. And in patients with irregular corneas, I noticed, John, on one of your slides, there was an exchange rate pre intraoperative aberrometry as high as 26%. I think if you got to be prepared for some big misses when the calculations are so, and David, you will attest to this, that sometimes you do your best, you collect as much data as you can, and your refractive misses are quite wide. So leave a manageable bag for two reasons. Firstly, you might have to go back in and get the lens out. Secondly, you had to do one YAG capsulotomy in these patients. It's not a fun experience. If you take the YAG through the central ring, as soon as you hit it, it leaves a very white pit, and it doesn't look too great, and I'm sure the patient then can't see through that section. So you're looking at doing a circular ring and trying to delay or leave as clean a bag as possible so that you don't have to find yourself doing early YAGs. What about Fuchs dystrophy? Some Fuchs patients still can be quite demanding and sometimes not quite understanding of the need for glasses at the end of the surgery, despite all the efforts of pre-op counselling. And you can do I find you can do what you think is excellent surgery, and still they come out with some astigmatism that they didn't have before because their cornea has adopted a new shape, and that can be regarded as a failure by the patient when all they need is a pair of glasses. But here's that same eye post-surgery, post-DMEC and IC8. And you just give yourself a wider landing zone. And so that's been successful for me in some as a phaco DMEC solution. Again, only in the worst eye. This is another patient's clinical image at week 2, post DMEC and IC8 with unaided vision of 6.5 and reading of about N6 and 8, and a great result for that patient. What about phaco DWEC? I found this is a great. I was excited to use this in combination for two reasons. Firstly, you're isolating or you're excluding some of the irregularity in the peripheral cornea in these patients, isolating the visual axis like we do with all the irregular corneas that we put this in, but also cut down the glare from the Fuchs in the peripheral region, and also as a third positive, you reduce the area that you really have to clear with a stripping procedure, which is important in these patients. And this is post-op results from a patient we saw last week with the phaco DWEC in both eyes, but in the eye on the left that's received the IC8 and unaided vision of 6.5 and a reading vision of 6.5. So a glasses independence result, sort of a refractive level result in a patient who came in with Fuchs and cataract, which is not something I've ever been able to talk with patients about before. also had some modest success putting this in. This is the first eye I ever put an IC8 in, which is a radial keratotomy eye. It's also the eye that taught me the importance of centration software, because this wasn't bad enough for me to go back in and adjust, but it was not quite centered on the visual axis or the place that I wanted it to be. And following that case, we use a digital image centration in all cases. That's enough for me to whiz through quickly. So thanks for the opportunity to talk.
That was excellent. Thank you very much. Now, we have a little bit of time for any questions. Probably the easiest way to do it is if people could put them to the chat. So we look down the bottom of the screen and see chat, and you can type something in there, because there are a number of people on the call. Wondering if if you put an ICL in and the patient has the graft and then the graft fails, have you ever just gone in and done a DSEC or a DMAC and left the ICL there? So such at the end of the cell count may not really be on the graft be such a big
no, that's a good point. I mean, I haven't done that graft, is still working for the time being, but I wouldn't do a DSEC. I definitely do a DMAC, because I'd worry about the inducing astigmatism with the irregularity from the stroma. But even if you do a DMAC, to be frank, you're still going to basically, you've still got a chance of basically inducing some astigmatism with that lens. But by then they may be older anyway. So then you might have to do cataract surgery and take out the ICL and take out the lens at the same time. So that might have to be an issue anyway.
Greg, do you have any comment on that?
Yeah, I think if they were seeing very well, and your goal is just to rejuvenate the endothelium, I think I would try, and try and leave it in.
Okay, I've got a question on the chat here from Path Shah. John, with the ICL you use, do you need to do a iridotomy beforehand? Yeah,
so the ones I showed were a mixture of V4Bs and V4C. So what we currently use now is the V5C. It's got a centriflow in the middle, but I find that if you're doing it in a myopic eye, in a patient that has an AC depth of less than 3, I still do 1 PI, even though that's not what they recommend. But it's just that a lot of Chinese people have very high axial myopia, but they have very shallow anterior chambers. So if I'm putting in somebody who's got a anterior chamber length shallower than 3, I will still do 1 PI, and then the centriflow is the central lens.
And will you do that at the time of the surgery, or do you pre-place that?
No, so most of the time I pre-place it with a YAG. In that case, the reason why I did it at the time of surgery is that he's a known steroid responder, so that's why I did it for him at the time of surgery itself. But normally I'll pre-place it, do it like maybe 2 weeks before with a YAG, just do 1 PI. Okay.
And then the next part of the question is, when it comes time for their cataract surgery, maybe some years later, is it difficult to get the ICL out?
Yeah, I've done a few. I mean, it's not that normally difficult to get the ICL out, because normally it's actually quite flexible. So it's actually quite, it's easier than doing a standard lens exchange, because the material is basically, the polymer is much more flexible than doing a standard lens exchange. So once you flip the lens out into the anterior chamber, it's actually a lot easier to basically cut it. There's some publications, I mean, I haven't done this, but there's some publications using a femtosecond laser to bisect the lens. So you flip it out into the AC and then cut it into, into half and then take it out. But since it's already been published, there's no point trying it now, right? So no, I'm only joking. I just use a normal IOL cutting scissor and stuff, and they're quite flexible to take out, and then just do standard cataract surgery.
Thanks. Greg, do you have any comments on that, or? That?
I certainly put very few ICLs in, and I've certainly never had to go and take one out yet. So I'm lucky not to have. I don't have any real world experience in that regard, but. For me, and it's sort of a kind of ICLs are a treatment of last resort in a very, very, very high cone who can't wear a contact lens, and there's not enough tissue to consider a topography guided treatment.
Great. Any other? Oh, here we go. Greg, why IOL prior to topographic PRK cross-linking and not other way around?
Yeah, I was going to ask that.
Fair question. We debated both of those things. I think that there are 3 kind of reasons. Firstly, number one, we thought, well, if we're going to both topography guided PRK and lens selection in keratoconus are kind of error-prone refractive calculations. But we thought we had a slightly better control over touch-ups with the laser coming second than with the lens coming second. That was one reason. Second reason was that the topography-guided planning treatments are quote-unquote tissue hungry at the best of times. They can be they can expend a fair. You can be burning through a fair bit of tissue with a standard treatment. And if we wanted to correct any, what we do, we incorporate a refractive treatment into the topography guided treatment at the same time. And our rationale was, well, if we can take these patients whose refraction is -15, -16, down to a -1 or 2, which we thought which we usually, even if we miss, we can do with a lens-based procedure. Then when we go to a laser as a second step, we're not treating any big numbers to try to improve the vision. We're treating sort of fairly small numbers. If we do a topography-guided treatment first, like there are counter arguments, and I recognise those. Like then okay, we might have a more regular corneal profile that might even take a toric lens or a regular lens. We might have a possibly a more accurate IOL calculation, but we don't know. The answer to that question is that I could see an argument in both directions, but we fell on the side of the lens first.
And then look, we're getting close to the end, but there's another question there on the chat. Greg, would you have enough corneal thickness to perform the topographic PRK? Those expecting that in patients with moderate to severe keratoconus, they might be quite thin.
Yeah, I mean, we've been doing topography guided PRK for keratoconus. I started to train in that when I was a fellow 10 years ago. I think I gave my first talk on this 10 years ago at the APAA 10 years ago. And every time I give a talk, somebody says, well, how do you have enough? How do you do that if you don't have enough tissue? I think the presumption there is, well, first of all, there's no treatment plan that we go through with that doesn't leave a residual stromal bed of at least 250 to 300 microns, assuming a final corneal thickness of 300 or more. There's no treatment that is not combined with cross-linking to combine or to improve the strength of the residual cornea. And in all of the time we've been doing this, my personal series in Australia is now nearly 200, I think. We don't have any cases of secondary ectasia. What we do have is about a 5 to 10% rate of subsequent consecutive hyperopia. So the problem in these treatments that plagues topography guided and collagen cross-linking treatments is not excessive weakening and ectasia that you can't control. It's that the cross-linking is too strong, is that they can flatten too much. So yes, there are cases who would not be able to have a topography guided treatment because there's not enough tissue to begin with, but for the most cases, if you've got what you plan to be an adequate corneal thickness, then they are candidates. And that also speaks to the point that why do we perform the lens first? Well, we're trying to reduce the numbers that are going into the computer.
Thanks, Greg. Any comments on that, Jod? Or
no, I think you can, like I said, I think you can argue it both ways. But what I was going to say was it'd be quite interesting to see. There must be a maximum K that you probably think is okay, and the problem is that the profile of the cone is going to really dictate, I think, what's going to be the best option that you basically go for. But you need a massive series really to really start analyzing it on topography, and maybe and a lot of times when people think about cone, when they think about keratoconus, you're not looking at it could be early cones, things like that, not those frank like really severe K readings. And when I saw the results for the cataract surgery in those steep cones, they're terrible. Basically, they're terrible. So whatever you do, you're going to do better than what most people are doing because the results are just disaster. So,
Well, that's a good note to almost end on. Except we just have one more query. Greg, do you have any patients with loss of best corrected vision after topographic PRK?
Yes, we do. So any laser treatment's got to have a safety percentage, and the safety would be how many patients lost BCVA. And out of that series, there's 3 patients who have loss of BCVA as a result of the treatment, and they are ones that by the way, they're the ones that I'm aware of, because some of these patients are young and are quickly lost to follow-up after 2 or 3 years. They don't want to come back. But one of the things that can lead to loss of BCVA in that combination treatment and in regular cross-linking is unacceptable haze. And what we've learned about cross-linking over the years is that if you're not supplementing oxygen, if you're doing any accelerated treatment and you're not supplementing oxygen, you're more likely to get that happen. So over the time that we've been working on that combined therapy, the laser nomogram has been improving and our cross-linking technique has changed. And those early haze, those patients with increasing flattening haze, we believe now are due to unfavorable cross-linking reactions that we aren't seeing anymore since we switched to a different technique. What is that technique? We basically pulse every treatment and we supplement oxygen, which has now become a standard part of what Irregular is offering, I believe, with their new system.
Using much in the way of steroids after the treatment?
Yeah, all these cases get mitomycin as part of the treatment, and then a post-operative steroid. But the post-operative steroid is 1 or 2 drops a day until re-epithelialization, and then we increase quite significantly.
Excellent. Okay, well that's fabulous. Now, if anyone, I thought that was very informative. Thanks, Jod and Greg, for your contributions. Thanks again. Thanks everyone.